Welcome back to the Deep Dive, where we take your stack of source material and transform it into the critical knowledge you need to be well-informed. Today, we are undertaking a deep dive into the really high-stakes world of medical AI, specifically that critical intersection of large language models and, actual clinical decision-making.
And we are dealing with a problem that is, it's truly massive. The sources you shared, they paint a very sobering picture of healthcare right now. They highlight a figure that just stops you cold.
The 800,000 number.
Exactly. Medical errors are responsible for 800,000 Americans being dead or seriously disabled every single year. That is a failure rate that, well, it just begs for some kind of technological intervention.
That figure, 800,000, it's just stunning. So if the current human system is failing that badly, what specific type of error are the sources pointing to? Is this about fatigue, inconsistency, or just missing patterns that are too subtle for the human eye?
Well, it's really all of the above. The
Yeah.
central challenge we're facing is figuring out if AI can help us get to a new level of clinical accuracy without, like you said, introducing a whole new set of really high consequence problems. The research we looked at shows AI is capable of things that look, frankly, superhuman. But those same studies, they reveal a deep fragility and inconsistency when these models are pushed, beyond their comfort zone.
Right, especially when humans try to actually use them in their day-to-day practice.
Exactly.
So this tension, this idea of magic versus the reality of brittleness, that's the core focus of this deep dive. We've structured the material around two core areas for you. First, we're going to look at the huge established success of AI in pure image analysis, the machine eyes revolution, and then contrast that with the surprising weakness these models show in more complex reasoning. And second, we'll get into the human element. There's a fascinating new typology of how doctors are currently interacting with chatbots and what that tells us about what effective AI collaboration might actually look like. Okay, let's unpack this.
Let's start with appreciating the revolutionary potential here, because before all the excitement around modern LLMs, earlier deep learning models, the ones focused on computer vision, had already made these huge breakthroughs in medical imaging. This is the area where the machine has, in some cases, already moved beyond human capability.
And the examples from the sources are really, really persuasive. Think about the retina. Researchers trained these deep learning models on over 100,000 retinal images, and the test was simple. Could the AI predict a patient's sex just from that scan?
And human retinal experts, right. The specialists who spend their entire careers looking at these images, they could only manage about 50% accuracy.
So basically a coin flip.
A coin flip. They were performing at chance level. They just couldn't see the distinguishing features.
How about the AI?
It got it right 9 to 7% of the time.
Wow.
Yeah. The machine eyes were seeing, they were identifying and correlating features that human practitioners didn't even know were relevant. This is a profound shift in perception.
And that capability, it basically transforms the retina into this access point for the entire human body.
It really does. What's so fascinating is the sheer range of non-traditional diagnoses the AI can pull from that one simple scan. We're not just talking about, glaucoma anymore. The models can predict heart attacks and strokes. They can track the control of chronic conditions like diabetes and high blood pressure, and even detect kidney, liver, and gallbladder disease.
It even extends into the future. They can predict things like Parkinson's and Alzheimer's disease up to 7 years before clinical symptoms even show up. If that doesn't underscore the revolutionary potential of machine vision, I really don't know what does.
And it goes way beyond the eyeball, too. The models are finding hidden information everywhere. Take the electrocardiogram, the ECG, which traditionally just reads your heart rhythm.
Right.
The AI reading that same ECG can now determine the patient's hemoglobin level, a key indicator of anemia down to a decimal point. It can also diagnose hypothyroidism and serious kidney disease, all from a test designed for a completely different purpose.
So the models are essentially repurposing the data we already collect. One of the, let's say, more challenging findings, though, comes from analyzing chest x-rays. The AI, just by looking at the image, can accurately determine the patient's self-reported race.
Yes, and that finding immediately brings up huge questions about bias and privacy, of course. But from a purely technical standpoint, what the research confirms is the depth of the pattern recognition power these models have. They're linking these minute, spatially distant features in the image things that aren't even obvious to a human radiologist to these very complex systemic data points. It confirms the machine is seeing patterns in the data that are fundamental to our biology, for better or worse.
And bringing this back to the clinical workflow, this superhuman consistency is what really matters. Our sources highlight that these vision aids offer a critical gift of time and the potential for keyboard liberation for doctors buried in admin tasks. And we see this benefit proven out in 21 randomized trials of colonoscopies, where machine vision aids picked up polyps better than gastroenterologists who are working alone.
And there's a nuance there that speaks directly to human limitations. The AI was significantly better at detecting polyps later in the day.
Ah, so when the doctor gets tired.
Exactly. These models don't get tired. They offer a consistency that human practitioners, they just can't sustain across an exhausting 12-hour shift.
That consistency is the great promise. But let's pivot to where it all starts to break down. If machine vision is so reliable, why are we hearing so many cautionary tales about the next generation of AI, these large language models that combine text and images?
And this is where it gets really interesting. Because the high scores that LLMs get on standard medical benchmarks, they often hide a deep-seated brittleness, especially when they move to what's called multimodal reasoning, so combining the text of a patient's history with a diagnostic image. Passing a test in a perfect, clean setting is one thing. Performing reliably in the real world is something else entirely.
So to expose this brittleness, researchers used what they called adversarial stress tests on these frontier models, like GPT-5 and GPT-4o. They used really challenging benchmarks from major medical journals. They were essentially trying to confuse the systems on purpose.
They were, and the results were pretty alarming. The first key vulnerability they found was a reliance on intellectual shortcuts. So look at the input omission test. They took away the critical diagnostic image, leaving only the text. Logically, the model should fail, right? Or at least abstain, because it's missing the main piece of evidence.
But they didn't fail completely, did they?
Not at all. They still scored well above the 20% chance level, sometimes hitting around 40% accuracy, even with no image at all.
So what does that tell us? That it's just guessing based on the text?
It suggests the models are leaning on textual cues, or maybe memorize associations, rather than engaging in any real visual understanding. If the text describes classic symptoms for one disease, the model can guess the answer without ever looking at the image. And that completely undermines trustworthiness in any case where the image and the text might not perfectly align.
They also found a kind of superficial reliance in the format sensitivity test. They took text-only questions and just randomized the order of the multiple-choice answers.
And even that tiny change, something a human would never be thrown off by, it actually reduced the model's accuracy. It proves they're relying on things like positional biases, just superficial formatting.
But the test that raises the biggest red flags for me about trust was stress test 5, visual substitution.
This one is really clever. They kept the original case text, kept the answer choices the same, but they replaced the correct diagnostic image with a clinically plausible image, but one that corresponded to one of the distractor options.
And they asked the AI to integrate that visual change and adapt its diagnosis.
And the performance just collapsed. Across the board, we saw sharp drops in accuracy. I mean, GPT-5 dropped by over 31 percentage points, Gemini dropped by more than 33.
So that sharp drop is the key piece of evidence here. It's confirming what they call a failure of adaptive multimodal reasoning.
Exactly. A robust diagnostic tool has to change its answer when the physical evidence changes. The fact that performance just cratered shows these LLMs are relying heavily on static pairings of images and answers, or just pure memorization. You change one element, and the whole house of cards is exposed.
And if the models can't even get to the right answer consistently, what does their internal logic look like? Which I think brings us to the most concerning failure mode of all. The hallucination problem.
Right. So when you press these LLMs to justify their diagnosis, they often fabricate these deeply convincing but totally flawed reasoning traces. The study found two main types of failure. The first is hallucinated perceptions, where the model describes an image feature that just wasn't there.
So it's confidently saying, I see X, but there is no X.
Precisely. And the other failure is misgrounded logic, where it gives you a step-by-step analysis that sounds perfect, but it's based on that inaccurate or imagined feature. The output sounds eloquent, confident, medically sound, but the foundation is imaginary. And that's terrifying in a high-stakes environment because it makes it so much harder for a physician to spot the error.
Okay, so we have models that are brilliant at patterns, but brittle when you push them on new ones. Let's pivot now and look at the human side of this. Given all these flaws, how are physicians actually choosing to use these tools right now?
This research started by trying to solve a really interesting paradox. Earlier studies showed that the LLM, on its own, when a researcher fed it the full case, actually scored higher on medical problems than physicians who were allowed to use that same LLM as an aid.
Yeah, which is counterintuitive.
Very. So researchers wanted to know, was the amount of content the doctor chose to input the reason for this gap? Did the doctor simply give the AI too little information to work with?
And to figure that out, they identified 4 distinct styles of input, which created this new physician typology. And it's really interesting to see how even expert physicians fall into these typical user habits.
The first style they called the copy paster. This doctor just inputs the entire case vignette. Their thinking was, it's the easiest, it's the fastest, and it should give the most robust, context-rich output.
Makes sense. Then you have the selective copy paster. This person was more judicious, only copying what they thought were the most relevant sections, like maybe specific lab results. Their reasoning was often a fear of overwhelming the chatbot.
Third was the summarizer. Instead of copying anything, they wrote their own summary in their own words. This gave them the flexibility to frame the problem and focus the model on what they thought was most critical.
And finally, the searcher. This group used short, targeted queries, almost like an internet search. They were just supplementing their own thinking with a very focused question.
So when they compared the clinical case scores of the doctors using these 4 different styles, the central finding was completely unexpected.
What was it?
No single input approach was associated with scoring higher on the clinical cases.
Wow. So it didn't matter at all. If you were a copy paster or a searcher, your final score was about the same.
Exactly. If content amount is irrelevant, then success must lie somewhere else entirely. Maybe in the prompt structure, or more likely in the physician's own critical post-processing of the output. It's a huge insight.
It really is. It shifts the focus away from just feeding the model more data and toward the doctor's own cognitive engagement.
It suggests that success likely depends on other factors, like assigning the LLM a specific role, or perhaps most importantly, how critically the physician engages with the output before they just accept it.
This study also highlighted some practical difficulties doctors are having. Physicians consistently dislike the chatbot outputs for management cases. So, tasks requiring a nuanced treatment plan.
Yeah, they describe the advice as too broad or unable to consider all the patient and setting specific complexities, and that led to them using the chatbot a lot less for those critical management decisions.
So this tells us that LLMs are, for now, better at diagnostic reasoning than they are at advising on actual patient care.
That's right. And if we look at testing on truly complex subspecialty level scenarios, we see that accuracy drop off a cliff, which just reinforces this need for caution.
And that's where we can look at the results of the open evidence and deep consult pilot study, which really pushed these systems by testing them on questions from actual medical specialty board exams.
And the overall performance was, frankly, underwhelming. The best overall accuracy achieved was only 41.0%. And on one platform, it dropped as low as 28.0%. I mean, this is not a passing grade.
And even within that, the accuracy was all over the place. On digestive issues, one system got up to 55%, but then it dropped all the way down to 30% for respiratory questions. So, the models are not uniformly reliable across medicine.
But here's a fascinating and potentially dangerous finding about repeatability. Despite the low accuracy, the model outputs showed moderate to substantial agreement between 2 different expert evaluators, which means the model gave the same answer reliably.
And what stands out there is the critical takeaway for you, the listener. The model may reliably give the same answer, but that answer is still often incorrect. High repeatability does not equal high accuracy.
And this strongly reinforces the professional consensus that AI has to be used as an adjunct to, not a replacement for, clinical decision-making. It really underscores why we need standardized validation, with multiple raters and a rigorous stress testing before these tools get deployed widely.
So what does this all mean for the future? We've seen these incredible, almost magical capabilities in image analysis, the machine eyes seeing things humans miss, potentially diagnosing conditions years in advance. But at the same time, we've seen this profound fragility, this shortcut reliance, and even confident, convincing, but completely fabricated reasoning when we stress test them.
And since we know the amount of information a doctor inputs isn't the primary driver of success, and we know LLMs are vulnerable to ignoring critical data or just making things up, well, simply having the tool isn't enough. We need clear, granular guidelines clarifying which tasks LLMs are good at, like spotting polyps later in the day, and which tasks, like complex management cases, still need very high human oversight. And crucially, we need to tailor training not just to the tool, but to the physician's own problem-solving style.
So our final synthesis then points to a challenge that goes beyond just engineering and really into human psychology. If an AI gives a confidently reasoned answer that is fundamentally flawed or hallucinated, how much must a physician rely on their own expertise and critical engagement to spot that error? Future research needs to focus less on general benchmark scores and more on controlled testing of prompting techniques and, really, training doctors on critical thinking. This highlights the necessity of purposeful training to turn a brilliant but fragile tool into a trusted, reliable collaborator. Because in medicine, we can't afford to simply pass the task off to a machine that might just be precisely wrong.